And it's real easy to laugh at this type of stuff. You know, when you talk about erectile dysfunction, the jokes can go on and on and on. And when you talk about urinary incontinence, the jokes with that can go on and on and on. But realistically, these are really important diseases because while they don't necessarily affect your quantity of life, as you can imagine, it can definitely affect your quality of life, right? The other thing to take note with both of these diseases is usually they're indicative of something else being wrong, okay? So that's something that you're going to have to remember from this class, because that's going to be really important. You know, whenever you're assessing these diseases, the first question you need to say is, well, what's the underlying cause? Because this might kind of be a warning sign to say, hey, wow, that's weird. Why does this person have erectile dysfunction? You have to look, well, do they have cardiovascular disease? Do they have some undiagnosed cardiac disease which is causing the erectile dysfunction, right? So it would be totally wrong to treat the erectile dysfunction if they have cardiac disease, because then what can you do? Precipitate a cardiac event, right? So you have to be real conscious of that. So again, both of these diseases are going to affect quality, not your quantity of life. So just some objectives. Discuss the most common causes of erectile dysfunction. And this is going to be very important. All these objectives, my questions will come from these objectives. List the current therapies available to treat erectile dysfunction, and also important adverse events and drug interactions with commonly used ED drugs. Okay, that's really important. And finally, if you have a patient case, I mean, this goes without saying, you should be able to choose the optimal therapy. And this is something that you've seen up to now in all of your exams. Okay? So who does this affect? So me, I'm 40, so I guess this is something I have to look forward to as I get a little older. And all the men in the room, this is something you should look forward to as you get older, including the BPH that we'll cover in today's lecture. So, don't get old, don't ever get old. Approximately 20% of men over the age of 20 have erectile dysfunction. That's an interesting number, right? 20%. Prevalence, of course, increases with age, and by the time you're 75, roughly 3/4 of men will have ED. And worldwide, if you look at the number of cases, 332 million, right? And that was by 2025. So this is a highly prevalent disease that you will encounter, so you should know a thing or two about how to manage it. So first off, physical or psychological stimuli. So the sacral parasympathetic stimulation to the penile nerves, and that's S2, S3, S4. This slide is informational. Dilation of the penile nerves, relaxation of smooth muscle in the corporal bodies of the penis, and you have decreased venous outflow. So let me translate what that means. You have for an erection to occur, you have to have either physical or psychological stimuli, right? So there needs to be some sort of stimulus, and this is important when we talk about treatment. And ultimately what happens is you have this decrease in venous outflow of blood, engorgement of the penis, and an erection occurs, right? So what happens in flaccidity versus an erection? Flaccidity, adrenergic norepinephrine, decreases cyclic AMP, smooth muscle contraction, decreased blood vessel filling. For an erection, cholinergic, non-anticholinergic, and VIPergic, increased cyclic GMP and CAMP, this is informational by the way, smooth muscle relaxation, and you have this increase in the venous blood flowing of the penis. Okay, so here's kind of a picture. So notice down here, you have the corpus spongiosum, okay? So what happens here, as you have kind of engorgement, you have a blockage of these kind of veins. So that prevents the outflow of blood, right? So that's kind of mechanistically what goes on. So as you have engorgement, you have constriction of the veins in the penis, and that basically prevents the blood from flowing out, and you remain kind of with an erection. Doing pretty good saying all this with a straight face. Pathophysiology. Erectile dysfunction may be classified as psychogenic. So 20% of ED is psychogenic. And look at this. Remember what I said. So ED could be related to some other underlying disease. So 80% of ED is related to some sort of organic cause. And you need to kind of do a very thorough patient history to identify what some of these organic causes might be. So it could be neurogenic, endocrinological, diabetes, vasculogenic, drug-induced, Systemic disease. What did you use? Systemic disease can also cause it. But the bottom line, who's messing with me? The bottom line is that, you know, psychogenic is 20%, organic is 80%, and a very thorough patient history is absolutely essential to identify what some of these underlying causes might be. All right. So this is important, okay? Psychogenic causes, you have predisposing, precipitating, and maintaining factors, all right? So predisposing, traumatic past experiences. Strict upbringing has actually been correlated to an increase or a predisposing factor for ED. Inadequate education, and just general physical or mental health. Precipitating factors could be related to acute relationship problems, familial or social pressures, and major life events. And then the maintaining factors, relationship problems, physical mental health, and lack of medical attention. So one of the treatments for ED is psychosocial counseling, right? Or seeing a psychologist or a psychiatrist and helping to address some of these issues that are here. So some of these may be addressable, right? So this could be the one option. So let's say it was related to acute relationship problems, right? Let's say it was a married couple, they were having some marital issues, and that resulted in erectile dysfunction. Well, they could perhaps go see a marriage counselor or some kind of psychological counseling that could hopefully help them overcome that precipitating factor there. Now, if we look at organic causes, we have neurogenic, endocrinological, and vasculogenic. So neurogenic, what would that be? Think of some of your neurologic diseases, multiple sclerosis, Parkinson's, stroke, Alzheimer's. And also you could have some injury to the cavernous nerve. So if you have an injury to the nerve in the penis responsible for an erection, that would be a neurogenic cause. Okay? Endocrinological could be related to androgens, could be a testosterone imbalance, and we'll cover that as well. Low testosterone, hyperprolactinemia, vasculogenic, endothelial dysfunction, and think about all of your vasculogenic diseases. Atherosclerosis, hypertension, hyperlipidemia, diabetes can also fit in here, and pelvic radiation. So for whatever reason, if someone had to undergo radiation for some kind of cancer treatment. Okay? So important to differentiate between the two. All right, so these are pretty important slides. Now just to continue with organic, we have drug-induced. So this is big as a pharmacist, right? You should be able to identify what are some drug-induced causes, because potentially one of the treatments could be to remove, right, one of the agents. So I could tell you when I'm on team rounding in the hospital and we start people on SSRIs, you know, sometimes I'll see like, you know, a 40-year-old and I'm like, guys, why are you starting that SSRI? You know, it's associated with 20% erectile dysfunction. Do you really want to do that to a 40-year-old? That's not cool. It's not nice, right? So you can make some pretty good interventions by helping people choose what is the most appropriate drug, especially in a younger individual who may be sexually active. Overall health, so liver, renal, respiratory, CV, and local penile factors. So some of the direct injuries to the penis can also cause erectile dysfunction. And priapism, right, is one of the big side effects related to erectile dysfunction drugs. So that's interesting because if a patient develops priapism to an ED drug, prompt treatment is essential. Otherwise, you can have even worsening, right? You can have worsening of erectile dysfunction. Okay, so this is an important slide. What are some drug-induced causes of an ED? There's a lot of drugs on here. So we'll kind of break these up into erectile dysfunction, decreased libido, blocked androgen receptors, and increased prolactin. Okay? And since I'm a really nice guy, I'm going to tell you to focus on that first column there. Right? So these are the drugs that are directly associated with erectile dysfunction. Now, note on the slide that's going to follow this, you're going to see some conflicting information. So don't send me any emails saying there's a difference in what you said on this slide and the next slide, because I'm going to explain it. And whoever wasn't here, they won't get why, but you guys will, so thanks for coming. All right? So the erectile dysfunction causes here beta-adrenergics, amphetamines, antiandrogens, anticholinergics. I'm not going to read through all of them. Beta-adrenergic antagonists are one of the greatest culprits. And the other thing with beta-adrenergic antagonists is they also cause depression, right? We know that. So when you start these drugs, they can dramatically influence or affect the development of erectile dysfunction. So if I had to choose between an antihypertensive agent, right, beta blockers would be at the bottom of my totem pole. I would not choose that agent if I have other alternatives. Now, sometimes you don't have a choice, right? So if someone has significant heart failure, the beta blocker prevents them from dying, right? That's pretty important. So in that situation, you don't really have a choice but to put someone on a beta blocker. The other thing you need to think about, if someone has significant heart failure, they may not have adequate cardiovascular function to either engage in a sexual activity, right? So when we talk about assessing someone's cardiovascular risk, that'll help you determine, whether or not you should initiate an antihypertensive or not in a specific patient, all right? Is that clear so far? This is a really important concept. So this is what is really important. So put a star on this, circle it. I don't know if you have a pink highlighter, use a nice pink highlighter, color the whole page in. Antihypertensives and erectile dysfunction. So all antihypertensives have been implicated. Now the question you should ask is, wait, Dr. Brunetti, you told me cardiovascular disease is an organic cause of erectile dysfunction. So what, do we not treat it? Does that make any sense? No, you have to treat it. And in fact, when you treat hypertension in someone who has erectile dysfunction, these drugs don't necessarily cause erectile dysfunction, which is an interesting finding that some have reported. So if you look here, all of them are implicated, but thiazides followed by the beta blockers are the most likely. So if you can, those are the two you avoid. ACEs or ARBs are the least likely, so that's likely what you would choose, right? And if you look down here, ACE or ARB is associated with improved erectile function and sexual performance in patients with hypertension and diabetes, okay? So this is where you look at risk versus benefit, understanding the patient's subtype, and that helps you determine what the optimal therapeutic choice is. Okay, good? Spent a lot of time on that, it's really important. Okay, how common are comorbidities found in erectile dysfunction? Hugely common. We'll start on the bottom here, but 90% of individuals with erectile dysfunction have some form of depression. So again, going back to psychogenic causes, and one of the treatments may in fact be seeking some sort of counseling. The other ones, if you look here, are some of these organic causes: diabetes, heart disease, hepatic failure. So just illustrating that, it's very common to see comorbidities in this patient population. And if you look at some of the other risk factors, age, of course, as you increase in age, poor physical and psychological health, metabolic risk factors, and lifestyle factors. So this really kind of just ties everything together, right? It's a multitude of risks. Diagnosis, so all of these diagnosis slides, I'm going to point out what I think is really important because there's several of them. So really, I don't want you to get bogged down with too many of the details, but I'll point out what I think is important, okay? So main goals would be establish whether ED is present, that's simple. Identify the cause, so you try and identify the cause, right? Ascertain risk factors. And again, the reason you want to do that is because you want to make sure there isn't some sort of undiagnosed cardiovascular disease or something like that, because that would be more important to manage versus the erectile dysfunction. So you need an adequate history. These validated questionnaires, the most commonly used one is this IIEF questionnaire. I took out the actual questions. If you're interested in seeing what types of questions they ask, Google it, you can find it. They're very subjective questions. One of the questions off the top of my head that's on there is, what is the quality of your erection? You have to kind of grade what your quality. So it's very subjective. There are objective tests that are kind of strange, but there's these objective tests where you could measure nocturnal luminescence. So essentially what that does is it measures your flaccidity or your erection in the night. So that's more objective evidence that there's something going on. Most of the time that is not done. We don't really do that. It was really weird. I'll never forget one of my professors that taught this lecture when I was in school. He told me he was a participant in an erectile dysfunction study. And I could never understand why someone would admit that to a student. I thought that was weird. But he's like, yeah, you know, I did the nocturnal luminescence. And I said, okay, I don't really want to talk to you anymore. But he was an interesting character. But I remember him from that, so it's kind of funny. Anyway, so this is the IIEF. So the way this is broken down is different domains, and it's 15 subjective questions. And depending how you score on these questions determines what the likelihood is that you have erectile dysfunction, and also what the severity of the erectile dysfunction is. Okay? So again, if you're interested, you can kind of take a look at that. You can just Google it. Now, the other really important thing you need to do before you say, okay, I made a diagnosis of ED, I think these are risk factors, so we're going to address the risk factors. But what you also need to do is identify what is their coronary risk. So why is that important? Why do you want to find out what their coronary risk is? Anybody? Real simple.
You can treat it if it exists.
Okay, you can treat it if it exists. Why else? The drugs we give interfere?
Determine if they're healthy enough to have sex.
Yeah, determine if they're healthy enough, right? I mean, you don't want to prescribe something for someone who's unfit, and then they go and engage in the deed, and poof, they end up in the emergency department. Not good, right? And that sets off a whole other problem because, you've seen these commercials on TV. What is one of the big contraindications of erectile dysfunction drugs? You ever listen to those commercials?
Yeah, if you take
Nitrites, right? So now, right, they end up in the ED with an MI. Maybe they're unconscious, we don't know, right? And we can't give nitrites, and nitroglycerin is one of the mainstays of therapy when someone presents with acute coronary syndrome. So really, really important, because you can turn a situation which is not so bad into a really bad situation by not just assessing the individual's coronary risk. So you should be able to do this given a patient case. I think that would be important to do as a future pharmacist. So if we kind of look at this coronary risk, you can split it up into low risk, intermediate risk, or high risk, okay? If you should end up encountering a case-based question, it will be very clear that they either are low risk or high risk, okay? There will be nothing in this kind of intermediate category, because then I could totally see 20 people lining up outside my office debating whether it was intermediate or high risk. I've been doing this a long time. Okay. So the other thing that's important to look at, and one of the reasons I would make it black and white, low risk or high risk, is because if it's intermediate risk, well, at the end of the day, you need to eventually get it down to whether it's low risk or high risk. All right? So sexual inquiry, ED confirmed, exercise ability, so sexual activity is equivalent to walking 1 mile on the flat in 20 minutes, or briskly climbing 2 flights of stairs in 10 seconds. So you can go practice and make sure you so the next thing you would do, of course, is that, right, low risk, intermediate, high risk. So you would place your patient into one of these categories. If you're high risk, well, then you stop, right? That means they're not fit, okay? And they would have to be referred to a cardiovascular specialist, and you would need to treat, and eventually you can reassess the individual's risk. If they're intermediate risk, you would go to a stress test, okay? And that would involve kind of doing a walk on the Bruce treadmill protocol. So that's just a stress test, essentially, okay? If you pass, you're low risk, you treat. If you fail, you're high risk, and then you end up in the cardiologist's office. If you're low risk, you're probably okay, but most people would probably suggest a stress test anyway, because again, one of the underlying causes often is cardiovascular disease. So again, you'll be referred to a stress test. If you pass, you're good, you can treat. If you fail, then you're going to be referred to the cardiologist. All right, is this clear? All right, cool. So this is somewhat of a complicated slide. So I'm not going to really require you to memorize this. I think it's unnecessary. I think it just highlights the point. Again, you usually have a patient who self-reports erectile dysfunction. Medical and psychosocial history, use of a validated instrument. So then you kind of do your initial assessment in your history. Physical examination. Then you do some laboratory tests. And ultimately, you can look at some of these situations here. And testosterone may be something that you evaluate as well, and we'll talk about that. You know, it was interesting, there's been a lot of controversy surrounding whether or not testosterone would be appropriate. The only time you would use it would be if someone did in fact have low testosterone, or low T, right? You've seen those commercials, low T, you've seen the low T commercials? So they've made low testosterone, they made it sound cool, so people aren't embarrassed to say I have low testosterone. Right, so it's, yeah, I have low T. So it's interesting how pharma manipulates kind of the word, and even erectile dysfunction, right? Nobody wants to admit they have erectile dysfunction. So how does pharma kind of get that to be more mainstream? Well, they get these high-profile speakers. The first, you know who the first speaker was? You might be too young to know, but Bob Dole. You know who Bob Dole is? He's a politician. He's a really old politician. And he was one of the first spokespeople for Viagra. But what that actually did is it made people more comfortable coming out. So on one hand, you can make the argument, it's disease mongering, they're inventing diseases to treat. But on the other hand, it actually helped people be less embarrassed to admit there was something wrong so they could seek treatment. So you can probably debate those either way. All right, so what are your treatment options? Overall goal is to improve the quality and quantity of erections. Non-pharmacologic therapies, lifestyle modification, psychotherapy, and yes, vacuum erection devices are a real thing. It's not a made-up thing. So we'll look at some pictures later on. Pharmacologic therapies, PDE5 inhibitors, prostaglandins, and testosterones. And I underline this PDE5 inhibitors because when you see the other therapies, you will understand why PDE5 inhibitors are the mainstay of therapy. You'll really understand why, because the other therapies are much more invasive and definitely not as convenient. And surgical therapies, that's really your last line. So that would involve some sort of prosthesis. So that's not something that you take lightly. That decision is usually made when there's no other treatments, because if you surgically go in and put a prosthesis in place, that's not reversible, right? So the surgery can in fact worsen erectile dysfunction. So you have to be pretty confident that this is the right decision before you do it. Okay, so here's the treatment algorithm. I'm going to read it from my screen here. I can't really see it there, so I'm going to come up here. So if we look at the treatment algorithm, so identify and treat the curable causes, so very redundant, you guys understand that by now. Lifestyle changes and risk factor modification, if you can. Provide education and counseling to patients and partners. Identify needs and expectations. So it's usually PDE5 inhibitors. I know this goes both ways, but really you should draw a bold line because PDE5 inhibitors is going to be your first line therapy. You don't really attempt these options until after you've failed PDE5 inhibitors. Now the other key thing, what is a PDE5 inhibitor treatment failure? You can't just say it's a failure because a patient says it didn't work. What you need to do is ask them important questions of why it didn't work, right? So some of these drugs, you know, if you take them with a high-fat meal, it influences absorption. For some of the treatments, you have to take it within a certain amount of time. The other thing is, remember, you need some sort of stimulus. You can't just take a PDE5 inhibitor and expect an erection to appear, right? You need some sort of stimulus, and some patients don't get that. So there's some education that has to go around. So before you tag someone as a PDE5 treatment failure, you need to determine whether or not it was a true failure versus user error. I'm not going to go through that in the interest of time. Lifestyle modification, stop smoking. Okay, that's like with every disease. So you can tell someone to quit smoking and it helps everything. And in fact, quitting smoking actually improves response to treatment in individuals with ED. So that's important. Weight reduction and physical activity. I'm not going to read through this again. So in general, lifestyle modifications is always a good recommendation to make because it even improves some of the underlying causes of erectile dysfunction. And now we go to the PDE5 inhibitors. These are really your first-line treatments. There's your mechanism of action. Essentially what happens is that PDE5 is the enzyme responsible for degradation of the cyclic GMP and the smooth muscles. And in doing so, it kind of allows more blood flow to get into the penis and allows for the development of an erection. The 4 agents in the US, sildenafil, vardenafil, tadalafil, avanafil. And again, if we look at the mechanism, sexual stimulation is still required. Okay, this is important because some of the other therapies it's not. Nitric oxide is released. Nitric oxide stimulates guanylate cyclase, and really what ends up happening is these drugs, and you could add avanafil in here too, it basically prevents the breakdown of that enzyme. Okay, so what is the comparison? So this is somewhat important to understand. The good thing is it shouldn't be that hard to remember because a lot of the information is similar between the drugs. So as an example, efficacy, they're all equally efficacious. And different individuals may respond differently to different drugs. But at the end of the day, they're all about 65% or greater effective in patients. If we look at the side effects, they're all very similar, right? Drug interactions, CYP3A4, they're substrates of CYP3A4, okay? Blood pressure lowering agents. So that's important because they can all cause additive hypotension. And this is especially concerning with nitrates. So nitrates are, that's a contraindication because you have precipitous drops in blood pressure. So significant hypotension. Onset is something important and is different between the different agents. So if you notice avanafil 15 minutes, tadalafil 45, 30, and then sildenafil 30 to 60. So that's really the onset of the drug. So the timing of when you take the medications would be important. Right, so if someone tells you that they took avanafil, I don't know, let's not use avanafil, let's say sildenafil 5 minutes before they were attempting to engage in some sort of sexual activity, and they're like, it didn't work, so I gave up. Well, if you only waited 5 minutes, it's probably not going to work, right? So that would be kind of an important thing to know. Now, with the dosage, many of these can also be taken daily. So that would be an option if you have an individual who maybe didn't respond to on-demand treatment, so taking it just when you need. They may respond if you take daily treatment, right? So it would be daily administration of these drugs. And just keep that in the back of your mind because one of the common comorbidities with erectile dysfunction is benign prostatic hyperplasia, or BPH. And PDE5 inhibitors can actually be used to treat BPH. So in those patients, if you have ED and BPH, it makes more sense to use daily treatment than on-demand treatment because you kill 2 birds with 1 stone. Okay, so that's important to remember. One big thing with avanafil, the dose, if you take it with an alpha blocker, should be halved. Okay, and that's because of the risk of hypotension. And we'll talk about some alpha blockers later on when we talk about BPH. But in general, there are specific alpha blockers you would use to prevent hypotension even with the other agents. Okay, some additional important information here. So fatty meals can cause a delay in Tmax. So for vardenafil and sildenafil. So that's important. And that's important for patient history. So, let's see, do I make this screen? I guess I'll make it myself. I don't care, I have no shame. So let's say, I'm on one of these drugs, and I take my wife out to a real, expensive date at White Castle, because I love that crave case. And I eat a whole crave case of burgers, high fatty meal, and then, I use sildenafil, and I took it about 15 minutes, on the way home or something, and then I was like, man, I can't perform, it's just not working. So was that a treatment failure? No, right? It's a Brunetti failure. I screwed up, right? Okay, so you get that. That's important, right? So if I put some kind of weird case like that, you have to understand, like, is it the patient failing or is it the real drug failing? So that's where some of these things might come in handy for understanding. Your contraindications are here. Alpha blockers, concomitant use with selective alpha blockers does not present a risk for hypotension. We'll talk about what the selective ones are when we talk about BPH. Okay? Now, one thing that I do want to point out, PDE1, PDE6, and PDE11, they're found in the heart, retina, and testicles. So what this is telling you, that you should have less cardiovascular effects with evanafil versus sildenafil. And you can also have vision effects with PDE5 inhibitors. So in fact, if you're on a PDE5 inhibitor and you develop changes in your vision, that might be related to the drug. So that should be something that prompts discussion with the prescriber and stopping therapy. But theoretically, because evanafil has less effects on PDE6 compared to sildenafil, you should have less chance of visual disturbance. Doesn't mean there's no chance, just means that there's less chance of visual disturbances. Okay? Okay. If you look at safety data, somewhat similar between the different agents. The one thing that's different with tadalafil is it has somewhat of a higher risk, or higher reporting, I should say, of back pain and myalgia. Okay? Interestingly enough, tadalafil is the one that has the longest half-life and kind of lasts the longest. So I'm not sure if that might be the reason you have this type of pain. We really don't understand the mechanism of why. So here's your safety, some warning and precautions, unstable symptomatic angina. A lot of these I think are self-explanatory. If you think about it, individuals who have these symptoms, they probably shouldn't even be on a PDE5 inhibitor to begin with. So some of them are real common sense, right? So you wouldn't want to give someone with uncontrolled hypertension a PDE5 inhibitor. That would be a bad idea. Class 3 or 4 heart failure, stroke or MI, a recent stroke or MI, moderate or severe valvular heart disease. I'm not going to read all of these, but this slide is very important for you to understand. And remember, just use common sense when you're assessing this, right? Because many of these you wouldn't even consider treating because you have significant cardiovascular risk, okay? Okay, so consider all the available agents, treatment failure after 4 attempts. So that's one important thing. You can't try once and say I failed, right? You have to try 4 times, okay? Consider daily use in patients non-responsive to on-demand use. And of course, educate the patient. Sexual stimulation still required, timing of dose, and dietary consideration. Okay, so testosterone. So we're going to switch gears. We're going to move away from PDE5. What's the role of testosterone replacement? There's a decrease in serum testosterone levels with aging and a time period when the prevalence of ED increases. So we know that testosterone, serum testosterone goes down as you age, and we know that as you age, your risk of ED also increases. So there's kind of a correlation between the two. And this is kind of interesting. We know that castration usually causes a decline in sexual function, and sexual function returns to normal in castrated men who have undergone treatment with exogenous androgens. So what this is saying is that if you castrate someone and you give them testosterone, things go back to kind of normal in terms of an erection. So that's kind of the proof of concept, I guess, of if you replace testosterone in individuals who have no or low testosterone, you should improve sexual function. So here's your normal range. I will tell you what the normal range is so you don't have to memorize that. This is informational here. It's a rare cause, but should consider replacement if testosterone is low. If testosterone is not low, then there's probably little to no benefit of using testosterone. Okay? Useful in combination with PDE 5 inhibitors in elderly men with low testosterone. Okay. All right, so you don't need to see this, but I guess this is important here, right? So must screen for prostate cancer at baseline and annually. So if you have someone who has a history of prostate cancer, are you going to give them testosterone?
Nope.
It's a bad idea. Don't do it. Lots of different preparations: buccal, topical, intramuscular, subcutaneous. Okay, so that's some of the important things with testosterone replacement, okay? So only if there's low testosterone, and useful especially if you're over the age of 65 with low testosterone and in combination with a PDE5 inhibitor. Okay? So now these other therapies, I'm not going to spend a tremendous amount of time on them because they're really infrequently used. And you're going to see why when you look at how you have to administer some of these. Now, they're second-line treatments. These are intracavernosal injection. And it is exactly what it sounds like. You're injecting directly into the penis. Okay? Advantage, rapidly achieve erection within 10 minutes. And this actually doesn't require any stimulation. So literally you inject and an erection happens. Yeah. Useful for men who failed or disliked PDE5 inhibitor therapy. Also useful for spinal cord injury or post-radical prostatectomy patients. And these are the drugs you would use: alprostadil, capavrin, and phentolamine. Okay? Those are the 3 drugs that have been formulated for this specific indication. Okay? Now, if you look, here's the max dose. Here's your adverse events: urethral pain, stricture, priapism. But look at the discontinuation rates, about 50%, right? So again, this is second-line treatment and may also cause pain, should be pain, not pain, for the female partner or male partner, vaginal burning, itching, pain, because if you think about the intraurethral, some of that drug comes out of the urethra during the sexual act, right? So as a result, it can cause pain to the partner. The intracavernosal, you don't necessarily have that type of side effect, right? Because that's injected directly into the penis. So here's kind of your administration. And this would be the intraurethral. It's this, kind of looks like a lancet, loaded with this like little pellet here, and it shoots it into your urethra. So as you can imagine, this is why it's second line. This is not the most comfortable thing to do. The other thing to keep in mind, I don't know how to make this sound. The other thing to keep in mind is you have to kind of be in a relationship where you trust your partner with this, if you think about it. So with a PDE5 inhibitor, you can kind of hide that. This is not as easy to hide with your partner. Because essentially when you're ready to engage in the act, you have to call a timeout, you have to go inject yourself, and you need to come back, right? So from a convenience factor, not very convenient, not as easy to hide from your partner. And then also the side effect, right? That's also something important to note as well. So this kind of is usually something that tends to be better in people who are in maybe more monogamous relationships with someone who they feel comfortable with. Okay. Vacuum constricted devices, we're not going to really talk about this, but there's your picture. Penile prosthesis, good, I didn't really want to explain that. Penile prostheses, so again, this would be your last line therapy. So essentially you would try everything before you went to this. And there's a couple different strategies. Now, there's this one down here, inflatable prosthesis. Is actually hydraulic. Some fancy engineer made this thing. 3-piece, most popular, very high satisfaction rates. 70 to 90% of patients and their partners were satisfied with the function of this. So here's kind of some pictures. This is kind of the reservoir here, and it has kind of, this is going to sound weird too. There's kind of a little trigger, and it's usually hidden beneath the skin and the scrotum. that you can essentially trigger, and it results in the engorgement of the penis. So these prostheses will fill up with some kind of fluid to cause an erection. But again, this is really last line therapy. Okay. So future directions, this is just informational. So we know that PDE5 inhibitors are not flawless, and notice the number I said is greater than 65% efficacious. So greater than 65 is not 100%. So there definitely is still room to come up with better therapies. But for now, they're probably the best therapies that we have. And I think it's pretty obvious when you compare it to some of the other therapies that are available. The convenience factor is just so much greater with the PDE5 inhibitors compared to the others. So conclusions, ED is highly prevalent and significantly impacts quality of life. I think that goes without saying. You know, all kind of the joking and smirks aside, as we kind of went through the slides, you can see how it can dramatically affect an individual. Treatment options are limited, but PDE5 is the mainstay of therapy. Pretty highly efficacious, greater than 65%. It's pretty good, but there's still room for improvement. And this is a huge role for pharmacists. Education. So that slide I had in there about what you want to educate your patient on, that's an important slide. You're going to want to remember that slide. Okay? Okay, so we're done with erectile dysfunction. So we'll go through a couple other urinary tract diseases or diseases of the urologic system. And the first one we'll spend a little bit of time on is urinary incontinence. So now this is something that affects both men and women. So, all right. So not something that just men have to look forward to as they get older, but urinary incontinence is also something that affects us. And one of the risk factors is advancing age. Not the only risk factor, but one of the risk factors. And again, urinary incontinence, like erectile dysfunction, doesn't necessarily affect your quantity of life, but it definitely can affect your quality of life. And also, it could be a sign of some underlying problems. Okay? So here's your objectives. Appreciate drug-induced causes of urinary incontinence. So you guys should definitely know, what is the most obvious cause, drug-induced cause of urinary incontinence? What? Say heroin?
No.
Diuretics, yeah. Diuretics. Sorry, I didn't mean to throw you in. I thought you said heroin. I guess if you're high enough that you can't feel your bowels, that could. But no, it would cause the opposite heroin, right? So diuretics are a big cause. And I can tell you in hospitalized patients, one of the most common reasons for patients falling is incontinence. I would say like 90% of the patient falls that I review are related to patients losing or, just losing it. Okay? Whether it's stool or whether it's urine. And a really simple thing you can do is not be mean and give someone diuretic at 10 o'clock at night. That's cruel. I don't know why you would do that to anyone. That annoys the heck out of me when I see someone prescribe a diuretic at 10 o'clock at night. Now, unless they're in critical care and, whatever. But just a general medicine patient, there's no benefit to giving it at night. And what ends up happening is people jump out of bed, they lose their, continence, they slip on their pee, and then they fall. Right? So don't give anyone a diuretic at night. It's bad. That's the most important message of this lecture. All right. List pharmacotherapeutic options for treating urge incontinence versus stress incontinence. Compare and contrast currently available medications for treating urge incontinence. So we'll go through some of the different drugs. I'll try and point out what are the first-line therapies and kind of the most commonly used therapies, as well as what some of the most common adverse effects are. There's a lot of drugs here. Again, I'm going to try and make it a little bit easier for you to go through these. So urinary incontinence is involuntary leakage of urine, frequently accompanied by LUTS, lower urinary tract symptoms. Okay? And that means urgency, increased daytime frequency, and nocturia. And again, this is going to impact quality of life. So prevalence 20 to 30% in young adults. But if you look, as you get older, it's more like 30 to 50%. For reasons we don't know, it's less common in African Americans compared to Caucasians, and half as common in men in comparison to women. So this is something that affects women a bit more than it affects men. results of abnormalities related to either the urethra, the bladder, or both. Okay? So it can affect the urethra, the bladder, or both the urethra and the bladder. Okay, and to make things even more complicated, we have many different types of incontinence. So these are kind of the main divisions of urinary incontinence. So if you look at stress urinary incontinence, this results from urethral underactivity, may occur secondary to exertional activities, right? So you have kind of, maybe, you know, the saying, you know, I laughed so hard I peed my pants? That's it. So that's how you remember that. I laughed so hard I peed my pants, right? Stress urinary incontinence may occur secondary to an exertional activity. Not very common in men. Usually, if it does happen in men, it's secondary to some sort of surgery or some sort of injury to the urethra. You can have urge incontinence. This results from bladder overactivity. So the majority are considered idiopathic. We don't really know why, but there's some sort of overactivity of the bladder. Mechanism is thought to be either neurogenic or myogenic. Overflow incontinence, this results from urethral overactivity and or bladder underactivity. Unable to completely empty, thus causing leakage. And this is really uncommon in both men and women. Okay? And then mixed, so combination of more than one type, functional incontinence related to comorbid conditions. So the two I would say that you should be most familiar with are these first two columns here. Don't worry so much about these. Okay? So what medications affect urinary tract function? The big one, number one, is the diuretics, like you mentioned. So diuretics are important. Alpha receptor antagonists, alpha receptor agonists. So that's interesting, right? So they both can affect the urinary tract, either one way or another. Right? And your effects are listed here. I'm not going to read through all of them. So this would become somewhat important to note. But I'm a nice guy, so you don't have to memorize all of these. But remember the diuretics, because I think that's an important one. Okay? And you know what the heck? You should know this one too. ACE inhibitors cause you to cough. Right? So if I give you a case and someone is on an ACE inhibitor, and then they tell you they cough and they have a little pee-pee, how are you going to fix that? You stop the ACE inhibitor, right? So we'll throw that in the mix because I think that's something that you should know. So if someone, you guys have had cardiopulmonary, so I guess this is fair game, right? So if someone was on an ACE inhibitor and they had cough and that was causing stress incontinence, what would you do?
An arm.
Good, you would choose an arm. So everybody would get that question right, except the students that didn't come here. So don't tell them. Clinical presentation, here's your symptoms. And this determines whether you have bladder overactivity versus urethral underactivity. So it kind of depends on what symptoms you exhibit. So if we look at overactivity, urgency, frequency with urgency, leaking during physical activity, well, just think about that. Your urethra, right? That's supposed to prevent urine from falling out, right? So that's your urethra. Amount of urinary leakage with each episode of incontinence, large if present, usually small. Ability to reach the toilet in time following an urge to void. If you have bladder overactivity, you ain't gonna make it, right? If you have urethral underactivity, you probably will make it. Nocturnal incontinence is rare with urethral underactivity, but more common with bladder overactivity. Okay? So lifestyle modifications, scheduling regimens. So this is how we potty train my daughter. Like, you will go to the bathroom at this time. So you put her on the toilet, she doesn't go, fine, we're coming back here in an hour. You will go to the bathroom. No, we'll go back in an hour. So you can do that in patients of advanced age too. And in fact, this is something they may do in nursing homes if someone has incontinence. So you have kind of a scheduled regimen. And the idea is that if you have this scheduled regimen, if someone sits on the toilet, hopefully they can get some of that urine out. And usually this kind of would be combined with, with other treatments, but definitely something we can do. Pelvic floor muscle rehab, so Kegel exercises, supportive interventions, commodes and diapers can be used as well. Okay, so what are some of the pharmacologic options? So first line, so star this, okay? And there's a whole bunch of them, okay? There's a whole bunch that you could use, but these generally are your first line. But hey, look what's preferred, oxybutynin and tolterodine. And that's usually because they've been on the market the longest. There's generics, and they're cheaper than the other ones. And we'll talk a little bit more about them in a couple slides. The TCAs are generally kind of second line, but this is usual if you can kill two birds with one stone. So for example, if you have someone who's depressed and they have incontinence, well, maybe a TCA is a good choice, right? But if someone's got a cardiac disease, you don't want to give them a TCA, right? So that's important. So really, these drugs aren't used all that often. They are, but usually, they are used, but usually in patients who have multiple diseases that can benefit. And topical estrogen, I'm not going to spend much time on that because they're marginally effective. Okay, this is an important slide. You have to memorize all the numbers. So I will ask you, like, what was the number? You guys, you don't have to know the numbers, but what you do have to know is this up here, right? Because that really stands out. Look at the oxybutynin IR versus oxybutynin XL. So they're the same drug, but the difference is IR and XL. If you notice, right, the XL tends to have less anticholinergic side effects. This is important. So the reason for that is the IR is metabolized into active metabolites, and your body doesn't have time to clear them because it's occurring so rapidly. So they accumulate and they cause anticholinergic side effects. The XL, because it's more of a slow release, your body has time to get rid of the metabolites and they don't really accumulate. So you end up having less anticholinergic side effects. So the same is true for tolterodine. So if you have the option, you should use the XL formulation because you have less anticholinergic side effects. And this is especially important in your elderly patients who are at an increased risk for falls, right? Because you don't want those anticholinergic side effects. Okay, urge incontinence treatment, anticholinergics first line, typically tolterodine, oxybutynin preferred. And there you go. You could do botulism. That's just informational. That's really at the end of the line when nothing else works. All right, stress urinary incontinence. First line, most adverse effects diminish with time. That's duloxetine. So that would be your primary treatment choice there. Interestingly, you could use alpha-adrenergic agonists, so pseudoephedrine and phenylephrine. This is an alternative first-line therapy for women with no contraindications. But remember, if you have someone that has cardiovascular disease, you don't want to use those drugs, right? So if you have any cardiovascular risks, you really don't want to use pseudoephedrine and phenylephrine. You could use these bottom two, but that's informational. You can just put an X through those. But just know that it's something you could do. Okay, so duloxetine first line, even though not FDA approved. Alpha-adrenergic agonists are alternative first line, but there's a lot you need to worry about, primarily cardiovascular disease. Okay? All right, any questions on that? Okay, so we're doing good on time. I'm going through 2 lectures in 1 lecture, so this is good. So the last topic we're going to cover is BPH, benign prostatic hyperplasia hypertrophy. Now this, we're kind of reverting back to what we saw in erectile dysfunction. This is obviously something that occurs in men. And again, as you age, this becomes kind of more prevalent, okay? So if we look at the numbers, 20 to 25% among men, 40 to 49 years, greater than 80% of men, 70 to 75 years of age. So very similar if you look back to the prevalence of erectile dysfunction. Again, as you get older, roughly 3/4 or more of individuals will have BPH. Many patients may not present with symptoms. Greater than 50% of men over 60 present with LUTS, lower urinary tract symptoms. And this has a significant impact, again, on quality of life, not quantity of life. So very common. There's a relationship between BPH, LUTS, and metabolic syndrome, diabetes, hypertension, and dyslipidemia. So again, just like erectile dysfunction, you probably want to do a nice, thorough patient history and identify if there's any cardiovascular risk factors that you need to address as well while you're considering treating the BPH. So that would kind of be an important consideration that you make. Okay. Pathophysiology, normal prostate, size of walnut, bladder is eventually affected. So basically, if we kind of look down here in this picture, this is your prostate, urethra, bladder. So as the prostate enlarges, right, you pinch the urethra, and by doing so, you're causing more urine to remain in the bladder. The bladder becomes distended, and over time, while being distended often, you end up with having, affecting the bladder as well. Okay, so you can have some permanent damage to the bladder with prolonged untreated BPH. Now, the interesting thing is not everyone with BPH needs drug therapy, because a lot of the symptoms are subjective. Now, some of the symptoms, are more severe. So patients could present with renal failure. They could present with recurrent urinary tract infections from the urine being down there all the time. But many patients are, they just have subjective symptoms. So hormonal changes that occur with aging contribute to this hyperplasia. So you have, as you get older, you have increased estrogen, you have this increase in DHT receptors, you also have inhibition of DHT metabolism. And you have this increased DHT, and ultimately at the end of the road, what you have is this increased cell size and proliferation in the prostate. So that's what contributes to that enlargement of the prostate that eventually kind of crimps the urethra. Okay. So another way of kind of looking at it here, again, this is the prostate, this is your urethra, this is your bladder, alpha adrenergic receptors, lots of them in the prostate, you also have some in the bladder, right? So one of the mainstays of treatment is blockade of those receptors, right? You don't need to worry about that. So here's a good slide, I think, that goes over all of the different treatments and where they act in the bladder, or the urethra for that matter. So again, prostate, urethra, bladder. So muscarinic receptors, you have those in your bladder. Alpha adrenergic receptors, you have those in your prostate as well as the wall of the bladder. PDE5 enzymes are actually in the bladder as well as the prostate. So going back, if you have erectile dysfunction, you could benefit with a PDE5 inhibitor because it treats not only the ED but the BPH. But remember, all the same considerations apply on whether or not that individual is appropriate for a PDE5 inhibitor, right? So you still need to do the coronary risk assessment and all that, regardless if you're using it for BPH or if you're using it for erectile dysfunction. Okay. So how do you present? General presentation, no acute distress unless moderate to severe symptoms. Symptoms, urinary frequency, urgency, I'm not going to read through all those. Signs, enlarged prostate, greater than 20 grams with no nodules. So why is that important? If you have nodules, that could indicate cancer, right? So that's something to keep in mind because as you get older, your risk of prostate cancer also increases. So this is something that you want to rule out before you just start treating someone for BPH. Prostate should be soft, symmetrical, and mobile. So one other thing I think that's important to note here, because this is something I bring up to my residents too, when we're on team and we're evaluating someone who's coming in with presumed BPH. If they're the person or individual is initially presenting, you want to rule out cancer. Now, I don't know if you've talked about prostate cancer in your cancer block, but PSA is an imperfect measure to assess cancer, but we still measure it, and it still has some kind of utility. Now, one of the things you do in BPH is you have to feel the prostate. But if you feel the prostate, that can cause release of PSA. So what I'm trying to say is that if you're going to rule someone out, you should measure the PSA before you do the prostate exam. Or if you do that prostate exam, don't even get the PSA because the value is not going to be of any worth to you. Right? You're going to have to repeat it again anyway. So that's just something to keep in mind as you're evaluating prostate cancer versus BPH. Okay. So one of the common questionnaires, or there's a validated questionnaire that's used, is this American Urologic Association BPH symptom score. And just like the IIEF for ED, this is relatively subjective. So I'll just read some of the questions. Over the past month, have you had a sensation of not emptying your bladder completely after you finished urinating? And the answers could be anywhere from not at all to more than half the time, or almost always. So depending on what your score on this is, determines how severe your symptoms are. Higher the score, more severe. Okay? In general, if you have less severe disease, you probably don't even need drug therapy. It's really up to the patient. If you have more severe symptoms, that's where you probably definitely need some sort of treatment, because if you don't treat, that can precipitate other things. And we'll talk about that in a minute. So some other diagnostics, BUN serum creatinine, because you want to assess whether the kidneys are being affected from holding on to urine. PSA to screen for prostate cancer. Okay? Very important to measure this before you initiate treatment as well, because one of the drugs that you use, finasteride as an example, can actually affect PSA. So you want to get PSA before you start treatment, before you manipulate the prostate. Peak void residual volume, peak urinary flow rate, and you could even do an ultrasound. So why would you do an ultrasound? And one of the things you might want to rule out is if the person has any stones. Maybe they have a kidney stone. Maybe that's contributing to their pain or some of their symptoms. So sometimes you'll do the ultrasound just to check that out. And also you can visualize the prostate that way too. So lower urinary tract symptoms, you have these storage symptoms here, voiding symptoms, and then post-maturation, your bladder feels full even after you're done urinating. Okay? Terminal dribbling as a result of constriction of the urethra. So in other words, you're done urinating, but even after you're done, you have some dribbling that occurs after you urinate. That would be a sign that the urethra is being affected. Okay? Some of the complications you could encounter, painful urinary retention, could lead to acute renal failure. You could have gross hematuria, and this is usually when your prostate gets so large in size that really the blood supply is being exceeded, and that causes some blood to come out in your urine. Recurrent episodes of acute BPH could also contribute to infections, whether they be kidney infections, so pyelonephritis, could also be just plain old cystitis, and that's because one of your mechanisms, right, to prevent infections is to get rid of your urine frequently. But in BPH, you can sometimes be holding on to urine for a period of time, so that can cause recurrent infections. Some bladder complications, and you could also develop chronic renal failure, and this usually is if you have this long-standing bladder obstruction. So this is not something that occurs in the beginning. These are usually things that are complications from, maybe unrecognized or untreated BPH. Okay, so really important to assess what is the severity of BPH, because the more severe it is, that's when we really have to say to the patient, hey, this is pretty severe. We should treat this to prevent some of these complications from occurring. So medications, maybe BPH symptoms might be exacerbated by meds. There's a list of them here. The big one that I want to point out is these anticholinergic agents and testosterone. So anticholinergic agents, I feel like in pharmacy school you're always taught avoid in BPH, am I right? That's a partial truth. Okay? So that's something that's always drilled into your head, but it's not 100% true. In general, you avoid, but it has to do with whether or not you have a significant residual amount of urine in your bladder. Because sometimes in BPH, your symptoms may be related to the bladder. And if that's true, some of these anticholinergic drugs may be useful. What you wouldn't want to do, though, is you wouldn't want to use an anticholinergic agent in someone who has a lot of urine stored in their bladder, because that can worsen the condition. So when we go through the treatment algorithm, I'll point out when you would versus when you wouldn't use an anticholinergic agent. And then testosterone I'll point out as well, because that's something important to know. So if you have someone with erectile dysfunction, right, chances are they may have BPH. So if they have ED and BPH, and oh, what do you know? They have low testosterone. Well, if they also have BPH, and you know it's severe BPH, would you want to replace testosterone, knowing that the efficacy is not tremendous? Probably not. You would just stick with a PDE5 inhibitor and see how the patient responds, and then you would make the decision at some point later on whether you would take this risk. Okay. So this is important, but I won't ask you to memorize the numbers. I will tell you whether it's mild, moderate, or severe. Okay, so severe is severe, moderate is moderate, mild is mild. Okay. Okay, this is important, and there's just some modifications I want you to make to this figure that I think are important. So you start off with your BPH. You can have mild symptoms. If you have mild symptoms, one of the treatments would be watchful waiting. You do nothing. You just watch. You just monitor the patient. Okay? And usually you would monitor yearly. If you have maybe the patient's a bit more concerned, you might want to monitor it more frequently than that, but you don't have to give any drug therapy. Now, if you have more mild to moderate symptoms, okay, but your prostate is less than 50 grams, you could just use an alpha-adrenergic antagonist. If you respond, good. You're in the clear. If you don't respond, you could consider surgery. Okay? Now notice here, if you have mild to moderate symptoms, but your prostate is large, greater than 50 grams, you see how there's this dotted line here? If you have mild to moderate symptoms, you can give a 5-alpha reductase inhibitor and consider adding an alpha-adrenergic antagonist. But I would say you would really only do that if you had severe symptoms. That's why there's this dotted line here. The reason for that is 5-alpha reductase inhibitors, they take several weeks to provide benefit. Alpha-adrenergic agents, they work pretty quickly, within days. So if you have something someone that has severe symptoms, wouldn't you want to manage the symptoms, right? So that's why you would use combination therapy if you had more severe symptoms, okay? But it depends on the size of the prostate. If your prostate is less than 50, you're not going to give combination therapy right off the bat. Is that clear? Okay. And then if you have severe disease with complications, you're going to go right to surgery. Okay? All right, we talked about this already. Treatment options, there's your alpha-adrenergic blockers. They relax the urethra, relax the smooth muscle in the prostate as well as the bladder neck. Appropriate and effective treatment alternatives for patients with bothersome, moderate to severe LUTS. And all currently available agents appear to have similar efficacy. So there's a lot of drugs in this class. In terms of efficacy, they're all very similar in efficacy. So we don't have direct comparisons. So anyone who says, this drug is better than this because, in our study we provided more benefit, that's making an indirect comparison. When you can't really make those types of comparisons. There's really no good head-to-head studies that have said one agent is better than the other. Some of them are more expensive if they're newer, but alpha-1 receptor blockers. So more specifically, alpha-1A. So underline this sentence because this is important. Alpha-1A is concentrated in the bladder, neck, and the prostate. Drugs specific for 1A may have a therapeutic advantage, and the reason for that is you have benefit without influencing the cardiovascular system. Because alpha-1B, right, that's more important for the cardiovascular system, and that could influence blood pressure. Okay? And in general, when you start someone on one of these drugs, you get about a 4 to 6 point reduction in that AUA score index. Okay? All right. So here's just a comparison of some of the different drugs. Sulfa allergy next to tamsulosin or Flomax. Okay? You don't have to memorize the doses or the half-life or the time to peak effect. I guess you don't need to memorize anything on this slide, huh? Maybe that. We'll give you one thing to memorize. Tamsulosin, self-allergy. All right, so what are some clinical considerations? To me, this is a much more important slide. So first dose syncope, orthostatic hypotension, dizziness, they're all characteristic side effects that you can see. Usually you overcome this by titrating the dose. You start at kind of a lower dose, and you titrate it up to patient response. Patient counseling is also important for orthostasis. So what you don't want is someone to initiate therapy and not tell them that hypotension can happen, right? Because what happens is they jump out of bed, they stand up, and they fall down like a sack of potatoes because they had orthostasis. So it's important to counsel patients on this. Now, additive blood pressure lowering effects is less likely with alfuzosin than other second generation agents, but the least likely, tamsulosin and silodosin. These are the least likely because they're the most selective for those alpha-1A receptors. Okay? So if I give you this big laundry list of drugs to choose from, you'd want to choose one of these if hypotension is a concern. So when might hypotension be a concern? What's that?
Elderly?
Okay, elderly. What else? Yeah, if they're on antihypertensives or they're on other drugs that can have additive hypotension, right? So you'd want to choose the therapy that has the least risk of hypotension. So that's how you would clinically use this information. Tamsulosin may affect ejaculatory function. 90% of patients experience decreased ejaculate volume. 35% of patients experience anejaculation. And alfuzosin has not been found to be associated with anejaculation. So that means no ejaculate. Okay. Now notice this doesn't say erectile dysfunction. There's a difference. Okay, so that's important to note. However, if there is a couple, and I guess maybe this will tie into your later lectures, that's trying to get pregnant and they're not able to get pregnant, if someone is on one of these drugs, that might be one thing that you consider removing if possible. Right, getting rid of one of these drugs because that might increase the likelihood of getting pregnant. All right, we already talked about this. Wow, you guys named all of them. You're good. Did you peek ahead? Whoever gave you the answers? You guys are good. This is exactly what we just said. All right, here's kind of another important side effect. You can't have a talk about BPH without talking about a floppy iris, right? So floppy iris syndrome is kind of a weird side effect that occurs, but it is something we have to take seriously. So this happens intraoperatively. So intraoperative meiosis despite preoperative dilation, and you have this billowing and prolapse of a flaccid iris during cataract surgery. So this can be a significant side effect and can permanently damage your eyesight. So importantly, the risk has really been established with tamsulosin, lower risk with older, earlier generation agents, and it's associated with risk with 14 days of surgery. If you use tamsulosin or these drugs, it can cause floppy iris syndrome if you're undergoing cataract surgery. So you have to withhold therapy in someone who's undergoing cataract surgery. So one of the questions that they should ask in anyone who's getting cataract surgery when they're the pre-op testing, they're going to ask if you're on tamsulosin. But it's important as pharmacists to know that as well, because if you have a patient who's, maybe you're friendly with in the pharmacy, hey, I'm getting my cataracts taken care of, and they're picking up their Flomax, well, you got to stop it, right? You got to say, hey, you know that you shouldn't take this in the period prior to your surgery. You should probably contact your ophthalmologist to make sure it's still okay to proceed. Now, 5-alpha reductase inhibitors, finasteride and dutasteride, they both inhibit types 1 and 2. No data, well, you have type 2 with finasteride, type 1 and 2, but there's no data to say there's any difference in efficacy with this different selectivity in the specific enzyme that it inhibits. Should not be used to treat LUTs. So in other words, if you have severe symptoms, these drugs aren't going to work, right? Because they're going to take several weeks. In several weeks they'll work, but if someone has severe LUTs, you're going to want to use a 5-alpha, not a 5-alpha, you're going to have to use an alpha-adrenergic blocker. Okay? Finasteride also suppresses VEGF, and there's some evidence that there's a reduction in bleeding transfusion requirements in those getting TURP. And TURP is transurethral resection of the prostate, so it's a surgical procedure. Minor adverse effects, decreased libido, erectile dysfunction, so tie that with ED, decreased ejaculation, and gynecomastia. Their pregnancy category X, caution for secondary exposure, right? Serum PSA levels decreased by 50%. So remember how I said you have to measure the PSA before you start this therapy? Because you can have a falsely low PSA if you start therapy then measure it. This is just FYI. Okay. So back here, so this provides a little bit more clarity on when you would use both. So both would be appropriate for patients with LUTs associated with demonstrative prostate enlargement, that's prostate greater than 50 grams. PSA, right, greater than 1.4, and or enlargement on DRE. So we're assuming if I tell you the prostate is 50 grams, you don't need to do a digital rectal exam. I'm telling you the prostate is 50 grams. So you know that it's an enlarged prostate. And if your PSA of at least 1.4, you would consider using combination therapy. The other thing I would put here is if the individual has severe LUTs. Okay, so they have severe symptoms. Okay. Or just put info on this. I'm not going to hold you to that. Okay. Comparison of the different agents. You don't really need to know kind of the difference between each individual agent in the class, except for that one slide where I told you no sulfa-allergy for tamsulosin, and you need to know the differences in cardiac risk between the different agents depending on selectivity for alpha-1A versus alpha-1B. But here the big thing to know for the alpha-adrenergic antagonists and 5-alpha reductase inhibitors, I would say that, this goes without saying. You should know that one affects the prostate size, one doesn't because of the mechanism. You should also know that disease progression is not halted by the alpha-1 adrenergic antagonist, right? That's really symptomatic relief because the 5-alpha reductase inhibitors, they ultimately shrink your prostate, right? So you can slow down the progression of disease. Okay? This is important too. Decreased prostate-specific antigen, PSA. So the alpha-1 adrenergic antagonists will not influence PSA, but the 5-alpha reductase inhibitors will. Right? So that determines when you'll measure, when you won't measure. Sexual dysfunction, adverse effects. Know that one causes erectile dysfunction, one doesn't. Right? We went through that already. And we talked about the cardiovascular risk factors already. So anticholinergic is also important. So appropriate and effective for the management of LUTs if the post-void residual volume is not elevated. And we'll just make it less than 250, so it's black and white. Depends on where you read, but we'll say it's got to be less than 250 before you would consider using that agent. Okay? Almost there. We already spoke about this. I'm not going to really read this slide. We said that the PDE5 inhibitors work. Informational. Complementary and alternative medicine, really not that much evidence that says that they work. The only one that has data that is somewhat positive is saw palmetto. I would not use saw palmetto for anyone with greater than mild symptoms. Okay? That's important. There's a large meta-analysis that was done that basically found there's no benefit in people with moderate symptoms, but some earlier studies have shown with mild symptoms, saw palmetto seems to work. And since you would be using watchful waiting anyway, if the patient is willing to pay for the saw palmetto, it's worth a shot. The risk for harm is low. Okay. You don't have to know this. This is just informational. Surgical treatment, also informational. There's a whole bunch of different types of surgery. You can do TUNA, transurethral needle ablation. You can do TUMPT, transurethral microwave heat treatments. And I won't read through all these others here, but this is all informational. They're all different types of surgical procedures. So urinary incontinence and BPH, they don't affect quantity of life. They definitely affect quality. Treatments should be individualized, right? So they should be individualized, and you should respect patient preferences. So as an example, if you have mild BPH, don't say, you know what, you should take an alpha blocker because you might have symptom relief. Well, if it's mild symptoms and the patient is telling you they're not so bad, respect that patient's wishes. Now, if there's severe symptoms, that's a different story, right? Because in that patient, you may need to treat to prevent further complications. All right, so that's pretty much everything. And I will try and post office hours for exam 3. I have class from 8 to 5 on Friday, so I'm going to see if someone can cover one of my sections so I can have office hours. Otherwise, I'm going to have office hours next week. What day of the week is usually the best for the class, besides Friday? Thursdays? So I forget where the course liaison is. Whoever that is, but you just send me give me 2 days next week that work, and I'll see if I can make office hours. The final exam, by the way, the date has been posted. I don't know if you saw it. I didn't put it on our website yet, our Sakai website, but it's May 8th. Okay. I believe it's 9 to 11. All right. Okay. Have a good day.
I just want to eat and go to sleep.
Why do you look so cold, shivering?
Where do you want to go eat?
Where? I brought some